Hello, this is part three of the OB review. Again, you could use this review for your upcoming proctor exam or for the final or any tests that concerns OB. So this is useful for many things. Anyways, let's get started. So I left off on the slide on the last for part two, but I wanted to go over this slide again because I added more information. So when we talk about fetal heart tones, normal fetal heart range falls between 110 and 160. And so I added the following acronym below here. So I wanted to add VEAL-CHOP. Okay, VEAL-CHOP is an acronym for non-reassuring fetal heart rate. For example, variable decels goes with cord compression. Early decelerations, you usually see head compression. Acceleration is okay. Late decelerations is associated with placental uterine insufficiency. So as you can see, I highlighted VEAL and CHOP. So if you remember VEAL-CHOP, then you could remember the appropriate components that aligns with them. So this is a helpful acronym that has helped many of you. Okay, rupture membranes. In order to confirm rupture membranes, you use a nitrazine paper. So it's a yellow strip of paper that's protected by light. And when you want to check to see if a laboring patient is ruptured, you dip it in the amniotic fluid. Well, if it's amniotic fluid, it turns blue. And if it doesn't turn blue, then it might be something else such as urine. So that's how you check ruptured membranes with the nitrazine paper. Another way also is to check under a microscope. So you get a sample of the fluid and you spread the sample along a slide and you look under the microscope, and if you see Christmas-like ferning, then it's positive for ferning. For ruptured membranes. And remember, I mentioned a couple slides before, the fetus, in order for a fetus to be engaged, they have to be at zero station. If the fetus is above zero station, then there is an increased risk chance of prolapse cord. More information about ruptured membranes. So especially for the term patient, if they rupture the membranes, it usually initiates labor, and most of the time they should deliver within 24 hours after rupture of membranes. If the patient is ruptured beyond 24 hours, they are at risk for infection, and this also puts both not just the mom but the fetus at risk as well. So when she ruptures her membrane, either artificially by the physician or the midwife, or spontaneously, you have to note the time that they are ruptured, the amount of fluid you see, the color, and also if there's any odor as well. This all needs to be documented. And after that, you should assess the fetal heart rate, because sometimes when they rupture the membranes, you might see an abrupt deceleration. So usually it resolves itself after the event, but beyond that, you should always continuously assess for fetal heart rate, especially when they're ruptured. So as far as the amniotic fluid, the components, it's usually pale to straw yellow. There should not be any foul odor. It's usually clear, watery, and normal volume is between 500 to 1200 mLs. And then I mentioned about nitrazine paper turning blue if it's positive for rupture. Some terms I kind of tossed around in the last couple of slides. Artificial rupture membranes, you might see the acronym AROM. It's not active range of motion, but it's artificial rupture membranes. So again, you should recall the baseline fetal heart rate prior to, if this amniotomy, let me just go back. That's something that's artificially performed by the physician or the midwife. So if they do rupture the membranes, then you have to note the fetal heart rate when the event occurred. Again, you should note the color, the amount, and consistency in the odor, and document all of these findings. Okay, let's switch gears and talk about pain management. One form of pain management is hypnosis. So hypnosis, it's usually a person who, a patient who decides to undergo hypnosis. They try to get advice from someone who's experienced in this field. And the theory of hypnosis itself, it's a heightened relaxation of the mind and body, and it encourages expectant moms to positively calming. So they're in there's someone that assists them to help them get into this altered. I don't think it's really altered consciousness, but they get this in this sense of mind, sense of their mind is in this particular way, and when they get them to this particular I don't know if consciousness is the right word, but maybe mood is a better description. So they get them in this mindset, this particular mindset. And so they suggest when they get this in the mindset, um, they are trying to focus on relaxation and ways to help them release the anxiety and the pain. Anything, it's not really a distraction, but it's just a particular way to get them in this altered state of mind to distract them from the pain that they're experiencing during labor. That's the best way I could explain hypnosis. I don't know if any of you have seen hypnosis and maybe in some shows but it takes you to a different state of consciousness or different mood. Of course, there's anesthesia that are used for various ways. For example, if a woman decides to have an epidural anesthesia, that's injected in the back, and there's also spinal anesthesia that's most commonly used in cesarean sections. And what happens? The epidural anesthesia is exactly what it is. It's injected into the epidural matter of the spinal cord. And as far as the nursing care, prior to the epidural anesthesia procedure, you need to acquire the CBC, specifically the platelet count, because if the platelet count is below 100, then that patient is unable to receive an anesthesia. The reason being is that if the platelet count is too low, then the patient will bleed out. They'll have excessive bleeding, and they won't be able to clot. Therefore, it's a danger if they have an epidural or a spinal anesthesia because they use a big needle to inject into the spinal cord, and that could cause, large bleeding and also lack of clotting as well. So it's contraindicated. And so we need to have a CBC prior to the epidural anesthesia and the spinal. Also, in addition, the physician or the nurse anesthetist usually order at least 1 to 2 liters of lactated Ringer's fluid. They need to have a bolus of these fluids in order to prevent them from having their blood pressures drop to lower rates. So they're going to have a bolus of lactated Ringer's just to ensure that the blood pressures don't fall during the procedure. And let's see what else. So you have a CBC, and then you also have the bolus of fluids, and then the nurse assists them with the procedure, the actual implantation of the wire. The process takes about probably 15-20 minutes. But after that, you have to continuously monitor the blood pressures. Because one of the complications of let me see the next slide. I'm sorry. Here, the next slide. So one of the complications of epidural anesthesia is that the maternal blood pressure could fall. And that's why it's very important for them to have a bolus. So you're gonna monitor the blood pressures pretty regularly, according to the hospital protocol. In addition to, you're going to monitor the fetal heart rate, because one complication or one occurrence that happens is that there's a possibility that the fetal heart rate may drop following the epidural anesthesia, epidural placement. So usually it's not, it's just temporary, and it just happens right at the moment when once the epidural catheter is placed and medication is placed in. But you have to watch it carefully, and you want to make sure that the baby's heart rate comes back to normal. There's those rare instances where it never comes back to normal, so you're going to have to treat it as a non-reassuring fetal heart rate. And in very rare instances, you might have to rush the patient after C-section. But many times that the baby's heart rate will rise and get back to its normal way. So, but as the nurse assisting a patient with the epidural placement, you could be monitored for the two main things is maternal hypotension and fetal bradycardia. Those are the two things that you can especially monitor following epidural placement. So when it does happen, here's some interventions that the nurse should do. Should always reassess right after the procedure. The physician usually likes to place them in a semi-failure position. And the reason why they do that, because they want to ensure that the epidural anesthesia is evenly distributed in both sides. However, as far as the fetus is concerned, you remember the vena cava. The vena cava is on the right side. So it's really important for the patient to be off her back. And it's preferably best for her to be on the left side, but she could go to either side, left or right, but left's better just because of where the vena cava is. So, but if you do see a drop in the fetal heart rate, you could reposition. And if that doesn't bring the heart rate back up, there's other things as well. We call it intrauterine resuscitation. That involves administer oxygen 8 to 10 liters via mask, or you might give IV boluses, usually with lactated ringers. Again, this is usually a temporary condition for the baby with the variability, and it should resolve itself within minutes. Okay, so there are, I forgot to mention, I'm sorry, the regional anesthesia, that's the third one. That's the one that's given, for example, like a pudendal block at the vagina. So if you anticipate that the patient's going to have an episiotomy, and the episiotomy is when the physician or the midwife does a cut at the vaginal wall, usually midline, and they do that in order to deliver the infant fetus safely, and you want to ensure to prevent the patient from tearing. So sometimes they do a small cut down midline along the vagina just so they won't tear. And they say with the episiotomy, once that is artificially performed, they suture them up, and these sutures are solvable, so you don't have to go back to the physician and get these sutures removed. So sometimes this is the preferred way to deliver vaginally, rather than tearing or spontaneously tearing. It's better to just do a small artificial cuts in order to regulate the incision, so it would heal quickly and probably maybe more improved healing process. And it's usually this lidocaine mixture they inject locally, and the needle, when you see it, it looks pretty big, but believe me, they're thinking more about the labor and the baby coming out than the needle of the anesthesia at this point. So anyway, so I just wanted to mention regional anesthesia as well. Okay. Getting back to complications of the post-dural puncture, this applies to more for the epidural and spinal anesthesia placements. So if you do have a complication of this, these are some of the interventions that the physicians prescribes in order to alleviate the complications. Usually the headache. The headache is just the worst headache that you can imagine. I had one with my son. I had a spinal anesthesia, and actually my headache didn't come probably about 2 or 3 days after, right when I went home. It was, and let me tell you, I think the headache was just like the worst headache I've ever had. I don't have migraine, so I can't compare it to migraine, but I could tell you that the headache is worse than the actual incision. It's pretty bad. So There are some things that they prescribe, such as an anesthesiologist could prescribe a blood patch or epidural saline. Um, the one that's commonly used is caffeine. So caffeine does work. So if you give them caffeine, that can alleviate the headache. Of course, hydration. If they're still in the hospital, you could give them boluses of lactated ringers. Sometimes they might have to do a surgical closure of the dura gap where the epidural or spinal placement was performed, and maybe the gap has to be surgically closed. And the main thing is to keep them supine. So when you hopefully when you see them going to recovery post C-section, you don't want the you prefer to have the head up as low as possible, maybe no higher than 15 degrees. So 30 above 15 degrees is too high. So you try to keep them in the lowest position as possible, maybe like 15 degrees, in order to prevent these headaches. But and I can't remember my recovery, but I don't remember how high my head was. I'm sure it was pretty flat because the nurses who take care of me were my coworkers and they're really good and I trust them. It was just that I had the headache. So what I'm talking about here is the little needle, the catheter's thread. So this is the epidural space, the outer part. It doesn't go too deep into the spinal. If it is spinal, then it goes a little deeper. Epi is not as deep as the spinal. Okay, let's talk about the problems of the passenger. Problems of the passenger is really, we're talking about the fetus. So one of the problems could be the prolapse, like I mentioned before, the prolapse of the cord. If that occurs, that's an emergency C-section. If you see the prolapse cord, as a nurse, your priority is to put your hand inside the vagina. You put your hand inside the vagina, but not just put your hand there. You're pushing the presenting part, which is the head. You push. Usually, you press the head up and off the cord, and you're going along in the gurney to C-section, and you can't take your hand out till the physician you're instructed to do so. Usually, at the end of the procedure, they'll tell you when to take the hand out, but your hand's stuck in there. So the priority is to put your with a gloved hand, take the head off the cord. You call for help to help you transport the patient to the operating room. You want to make sure there's some other things too. They say put them in Trendelenburg position, knee chest. Again, this is happening so fast. We're taking her to the operating room, and they say that if you have access to normal saline, to try to get like a 4x4 and drain saturated with normal saline and put it on the cord just so the cord won't get dried out. But again, these things are happening so fast. This has happened to me. It's actually, it was at Cedars-Sinai. I used to work there years ago. And of course, it happens in the middle of the night. It wasn't actually, fortunately for us, it was not that late. It was about 11 o'clock at night. So it was not like in the wee hours of the morning. And this happened to me. And I put my hand in there and did everything the book said. And the time from when I found the prolapse cord to the time it delivered, it was really fast. Fortunately, 12 minutes. 12 minutes is that's pretty fast considering from the time it happened to deliver the baby. So we were able to act quickly. So multiple gestation as well. That's a problem too. Usually there's C-section. But if they try vaginal delivery, there are complications. Anyway, I'm going to leave it at that. Okay, I mentioned about the prolapse cord in the previous slide. Remain in bed after the rupture of membranes to prevent this from happening. Push the head away from the cord, place them in Trendelenburg. This third step is probably your first priority. And then go ahead and put them in Trendelenburg. Okay, I'm going to switch the momentum here and talk about the stages of labor. The stages of labor, there's 4 stages of labor. But the first stage has 3 parts to it. Stage 1 is the latent phase, includes the latent, active, and transition phase. So make sure you look in the your ATI book to know the exact centimeters, because I know some textbooks vary regarding what is active, what is latent, but in general, latent is when they're not in active labor. They're just very, you could actually be, it's from 0 to 3 centimeters. And you could be like this for a long period of time before you go to active labor, which is usually 4 centimeters. And the key thing about 4 centimeters, and that's when their contractions start to become stronger. And usually, ideally, the anesthesiologist wants to wait till the patient's at least 4 centimeters before get the epidural, because the school of thought is that if you receive your epidural before 4 centimeters, it may delay your labor progress, and they still say that in many of the OB books. So, but now with epidural anesthesia, you could get it at any time. So now you can get it any time, whether you're 4 centimeters. You could even get it when you're 10 centimeters and get the epidural. If you're 1 centimeter, you could get the epidural, but it's best if you could try to wait till you're 4 centimeters to get it. So it's 4 to 7 centimeters active stage, and the transition is from 8 to 10. 8 to 10 is a trigger that you're starting to get ready to start to push the baby to get into stage 2. So that transition stage includes a lot of shaking. Sometimes the pregnant patient might end up being, they might get nauseous and vomiting. That's usually, you usually see a lot of shaking. And stage 2, they're pushing, they're 10 centimeters already, and this ends when the infant is delivered. And usually, sometimes it could happen as quickly as minutes, or it could be prolonged as maybe, I've seen 2.5 hours. 3 hours is kind of excessive, but you hope to 1 hour is ideal. So, but if it's the first baby, it usually takes a little bit longer, and then the pregnancies after that, sometimes it's faster, but it doesn't follow like that all the time. That's just in general. So the first baby is usually the longest, and then stage 3. After the infant's delivered, you're waiting for the delivery of the placenta. And then when the placenta is delivered, you want to make sure you have oxytocin in hand. So you want to start stage 4. You give the Pitocin through the IV in order to help the uterus clamp down. So you want the uterus, you give the Pitocin to keep the uterus firm, and the Pitocin helps with the involution process. Okay, let me explain this. So Pitocin, when you give Pitocin, it causes the uterus to contract. So the purpose of giving Pitocin is causing the uterus to contract, and the more contractions the uterus has, the faster that the whole involution process is going. So Pitocin is assisting in the involution process by causing contractions to the uterus, and the contractions will help the uterus contract. And so, it takes a lot of work, and I think I talk about uterine apnea a little bit later. So, there's some factors that affects the involution process. So, if it's the first baby, it might go accordingly. If it's the second, if you're multi-gravida, meaning it's the second, third, or fourth pregnancy, it may take more work. If you're multiple gestation, it might take more work. And the reason why I think of a uterus as a balloon, it's like this really, really tight balloon. So in normal pre-pregnant size, it's 6 to 7 centimeters. And so just think about this uterus as 6 to 7 centimeters, and every time you get pregnant, it expands to this pretty decent size, and big enough to carry as big as 5-pound baby all the way up. Like lately, I saw in the news a month ago, 15-pound baby. So the uterus could get to a pretty decent size. And so you give Pitocin after the placenta is delivered. And so this Pitocin is supposed to help make contractions for this uterus and get back down to 6 to 7 centimeters. It does. The more pregnancies you have, and if it's multiple gestation, it may not get back to exactly 6 to 7 centimeters. So the more times you become pregnant, it will take more work. and possibly more medications in addition to Pitocin. Just hold off. I'll mention that in another slide. So think of it as a balloon, and it would take more work to get back to that size. Okay. So stage 4 is the delivery is postpartum, the first 4 hours, but still stage 4 of labor because you're still monitoring when her bladder function is returning, especially if she's had a epidural anesthesia, so you're going to assess that. And it's usually about up to 4 hours after delivery of the placenta. Okay, let's talk about the newborn. So when the newborn is born, there are some key things, okay? The two most important things when the newborn is born is respirations and thermoregulations. So those are the two key things that you're going to be watching closely with the newborn, respirations and thermoregulations. And respirations, the cardiovascular and respirations go together. So that system itself is one concern. And then the second concern is thermoregulation. And so there is like a quick tool. I know OB nursing has a lot of tools. Bishop score, BPP. Well, I'm sorry. Here's another tool, APGAR scoring. So this tool consists of these components: heart rate, respiratory effort, muscle tone, reflex, irritability, and color. So those add up to a particular score. So you want to try to get to the highest score you could get is 10, but usually it's really hard to get to 10. And the reason why I wanted to point out is color. So most infants, when they're born, they don't. The color is usually this pink color, but usually the majority of the infants that are born don't have that pink color because on their feet and their hands they have a bluish color. And so therefore you cannot give it a complete 2, you give it a 1. So that's what causes the 9. It's usually because of color, and the blue feet and hands is acrocyanosis. So that's why, I mean, it's very rare that you see a baby has complete 10. So normally you do the APGAR scoring at the 1 minute and 5 minute milestone. However, if you do have a score below 8, then you're gonna you might repeat it at 10 as well. So if it's maybe 7 at 1 minute and then 5 minutes is 8, then you might go ahead and redo it at 10 minutes. So you kind of have to use your judgment. But if it's below 8, you're probably going to redo this APGARs at 10-minute mark. But the average APGARs is usually between 1 and 5 minute marks. Okay. Here's another slide that I love. It's about the transition to neonatal circulation. So I'm going to try to focus on this slide here. So once the infant is delivered and comes out of the womb, when it comes out into the atmosphere, into the environment, from uterus to the outside, and once the physician or the midwife clamps the cord, these 3 things happen. So I want to point out there's a whole little pathway of what happens to the neonate and how they transition from a neonate circulation to regular circulation. But once I want to point out here, when the umbilical cord is clamped, these things happen. You have the closure of the ductus venosus, and also the ductus arteriosus, and also too it talks about how these particular things happen in order, and this event, an increase in the left atrium pressure, this results in the closure of the foramen valley. These 3 things in the heart close when the cord is clamped. So I just love this slide. It kind of explains step by step what happens leading up to the closure of these 3 things. And these things close naturally when they're at term. When they're at term, they close naturally. However, if they're born, let's say for example Down syndrome, if they have Down syndrome, sometimes there might be a delay in closing of the ductus arteriosus. Sometimes they're born with it doesn't close, and so they might have to surgically go in and repair it. So that's an example. Or say that they are delivered before 36 weeks, or maybe even more premature, maybe 28 weeks. Sometimes these things don't close, and so they stay in NICU for periods of time till they acquire this healthy weight, and all the organs are fully developed and mature. And sometimes one or all of these may not close in a timely manner. And so, so again, clamping at the cord in the first cry results in the closure of these three things. Okay, a couple slides ago, we're talking about the APGAR score. Sorry. And so this shows like 0, 1, and 2 based on these things of heart rate, respiratory rate, muscle tone, and reflex variability and color. Okay. Okay, here's another tool. I'm so sorry. You're getting bombarded with all these tools. But this is called the Ballard scale score, invented by this pediatrician, actually. So with the Ballard score, it's a gestational age assessment to physically assess and measure. It's pretty scientific and pretty accurate of how many weeks they are based on the measurements. So they have these little parameters. They have two sections here: the neuromuscular section and the physical maturity section. The physical maturity section are the findings such as the skin, lanugo, plantar surface, so these aspects. And the others is more about the reflexes and how flexible they are. So there's this little specific, so you can read these at your leisure. But in general, the left side, when you go further left from these columns, they're usually less mature. They're a little bit they're not mature yet. Okay, so these, for example, this first column, they can't do these things. Like, say the popliteal angle. This diagram here, the legs go all the way back. They're very, very flexible. Those are usually associated with preterm babies. So again, the first column is the less mature, and as you progress to the right, it becomes more and more mature. So when you get to stage 5, that usually is post-stage. Column 4 usually is the term, and you notice from this stage all the way to the end, they're not as flexible. As they advance to the right side, they become less flexible and they can't do these things. But they do these little tests to see, to determine where they fall in these little boxes. Then you have to add up the score, and then they get this particular score, and you compare it with their gestational age that's established for, early in the pregnancy, either by ultrasound and by last menstrual period dates. So with physical maturity, I want to mention like lanugo is the hair. It usually starts off very sparse, and then they develop more. They have more hair, and so the more hair they have, they're not quite mature. When they get really mature at the end, they're mainly bald. They have less lanugo. That's called lanugo. Another thing they look at is the plantar surface. At preterm, they're not as defined. They're barely existent. When they when they become more mature, you see the creases of the entire sole. Another thing too, the ears. They're very, very flexible. They're not the cartilage of the ears are very, very flexible, and you can maneuver it. As you advance on and they become more mature, they become thick. The cartilage becomes thicker, and and the ear is stiff. But before then, there's some recoil, and as the more mature they become, there's less recoil and they become stiffer. And then also differences in the male and female genitalia as well. Okay, so a lot of hospitals still use this. Okay, the appearance of the newborn. As far as the head's concerned, you have the fontanelles. They have the anterior fontanelle here and the posterior fontanelle. And the anterior fontanelle is usually they're born slightly open, and it takes about 3 to 6 months to close. Actually, it could be up to a year to close this, but 3 to 6 months they close. And usually when they're born, the posterior fontanelle is closed when they're born. There might be some little occasional instances where it might be born, they might be born open, but in most cases they're born closed, the posterior. It's the anterior that's slightly open they're born with. There's this, you notice the sutures along the cranium here. And then we're going to look at the head as in terms of if it's molding or capsulocetonum or cephalohematoma. Molding means if the head, usually it could, it's not quite round. It's just a little bit of molding. But if it's not, capsulocetonum means they have this cone head appearance. And usually that happens when laboring mom is pushing for a long period of time, and they're kind of stuck in this the head stuck in the vaginal canal. So when they're finally born, they have this appearance of a cone head. But with capsulocetonum, I want you to know that it usually takes about 2 to 3 days before it gets back to the way it's supposed to be. Not like more of a round appearance. But it takes 2 to 3 days for capsulocetonum to resolve itself. And the capsulocetonum, the definition is the crossing of the sutures, so that's why it causes the coning. And it's usually more uniformly distributed. It's not just one side. When you have the capsulocetonum, it's both sides pushing this cone-shaped appearance. As opposed to the cephalohematoma, it's usually one-sided. It's usually maybe on, for example, on one side of the the head, the skull. And that's usually, for example, that occurs in a vacuum delivery. So if an infant is delivered via vacuum, they apply the vacuum extraction on the skull, and sometimes there are some instances where it may cause a hematoma. The hematoma takes about 2 to 3 weeks, usually on average, to resolve itself. But the one complication with the cephalohematoma you have to watch out for, because sometimes, because cephalohematoma, there's an accumulation of fluid underneath the periosteum of the skull. So when you accumulate this, this fluid, what could occur is jaundice. So you have to watch if they do have a cephalohematoma. You want to make sure that they don't have jaundice, and we'll talk more about jaundice a little bit later when we talk about direct Coombs and all that. So just hold your thoughts with jaundice. So anyway, so these are normal findings for the newborn as far as the head. And then when the measurements, when they take the measurements as far as how large the head is, they measure it around the skull, on the top of the ear, and they go around to the back of the head and like more at the midpoint, and go all the way down to the top of the eyes. So the top of the eyes to the top of the ears, all the way to the back is the head circumference. Okay, I mentioned before in the Ballard scale about the skin. So vernix sesosa is that white substance. You don't try to wipe it off. They say that this vernix is a natural lubricant. If an infant is born with a lot of vernix, that usually means that they're not quite term yet. They may be around like 37, 38 weeks, but they're not quite 40 weeks. Usually they mean that they're not quite. I remember working with these nurses. They used to call them half-cooked babies, but that's not the proper term. But she just said that fondly because they're being induced and they have a lot of vernix. Maybe they probably could have have an advantage and have more time inside the uterus, but they were induced, and as a result, they have vernix. Maybe the dates were not quite accurate. So that's what vernix is. Lanugo, as I mentioned before, is the hair. And as they become more mature, closer towards term, they are have less. They have more bald spots. Desquamation, it's kind of like these little lines, and they usually see this more when they become more term, or even post-term. They have lines, and sometimes they have peeling. And then milia is the little spots in the nose. Erythema toxicum is like the strawberry. They call it the strawberry patches. Is the redness sometimes, and forceps marks. I don't see. Unfortunately, I don't see too many forceps delivery. It's just unfortunate because I actually think that forceps delivery, it's an art. It's a lost art, and the newer obstetricians don't use forceps anymore. And I used to work at this travel on a travel assignment up in Washington State, and this doctor used forceps. And actually, it was a breech delivery with forceps. It was crazy because we had to use forceps because when the this laboring mom came in, the both feet were hanging outside the vagina, so you couldn't push the baby back in. The feet, both feet were out, so we had to deliver vaginally breech. It was probably one of the most. It's probably one of the top three most scariest deliveries I've ever witnessed. And so this doctor, very skilled, he was older, but you knew he knew his stuff. And fortunately, he happened to change his shift between the day shift and the night shift. And he used the cervix. I mean, the cervix. He used it like salad spoons. And I just remembered, there were many people helping. The lady was up in lithotomy position with her legs up, and they put this forceps around this infant fetus, and gracefully, put them in and pull this baby out as she pushed. And of course, the scariest part is when the head it was hanging inside the vagina, and then of course, like I'm like taking my breath like this. I'm holding it. I'm with the baby's head as well as the baby. I'm thinking, oh my gosh, the baby's head. That's like you're scared if you pull the baby out, that the head's not gonna it's gonna be stuck in there. You just don't know what to expect. But of course, that's your thinking that even though you know that's not gonna happen, but that's that thought because you try not to deliver breech deliveries by vaginal delivery. So, but I think someone was watching up there. God was watching, and they pulled the fetus out, and everything was fine. And fortunately for her, the infant was probably 6 pounds 2 ounces, and um, that was probably one of the most memorable deliveries. And it was in Washington State. I really had a great time in Washington, even though it rained every day, because I was able to work with doctors like that, where I didn't see too much here, like in the bigger hospitals. They did things up there that's still old school and traditional, but very I don't know. I was just amazed, very very amazed with that. Anyway, sorry I went off, but I'm going to talk about forceps here. Okay, as far as the eyes, ears, nose, and throat, so you want to make sure the eyes are clear. You want to make sure that the creases, the eyes, they're you want to make sure that they're aligned with the top of the pinna of the ears. If the ears are low lying, then you're going to consider it's Down syndrome. You look at the ears at both sides to make sure they're clear and it's patent. The nose, the same thing. You make sure there's the septum and everything's clear and okay. You're going to use a gloved hand, and you're going to put your gloved hand in the mouth and make sure that the cleft palate is intact. There's no cleft left palate issues. That the top of the roof and the mouth, and the tongue is all there, and the chest. So you're going to look at the chest and make sure it's symmetrical. You might have to there you do another measurement too as well. You get the measuring tape and you put it at the back of the infant, and make sure that the measuring tape crosses the middle of the nipple line. Then you're going to measure the chest in inches and centimeters. So centimeters is usually the one that they record both, but centimeters is the one that they record first. And also too, when you're in the chest area, you could go above the chest and look at the clavicles. Especially if it's a delivery that's a shoulder to social delivery, you want to make sure that there's no fracture. And the best way to check for a fractured clavicle is to do a more reflex, where you grab the hands and then you kind of like either you kind of drop the arms out and they go like this, okay? They kind of go like this. And if they do it symmetrically, then that more reflex, then you know that the clavicle is okay. However, if they do this and you see one arm go up and one doesn't go down, then you have to look at the affected extremity and make sure that there's no fractured clavicle. Okay, let's see here. Okay, let me see how much more newborn, because I might have to stop. I'm sorry, I just want to see how far I am. Okay, I might Okay, I'll go to the slide, and then I'm gonna have to go to part 4 because there's a limit for YouTube. Okay. Anyway, okay. So moving on to assessment to the abdomen 2, you want to make sure that they have bowel sounds, and 2, and then you want to note if whether there's any distension or not. And usually by ultrasound, you want to make sure there's no abnormalities. You don't want it, for example, there's that where and I forgot, I'm not the official term, but there's that incidence where the intestines are born on the outside, and unfortunately, I've seen that happen. And so, if you see that, if you anticipate that, they usually anticipate that before the infant is born. Usually, they're delivered by C-section, and so they usually transfer to a higher acuity hospital. But they usually use this it's not really saran wrap; it's kind of similar to it, and they try to cover it all the way up till they bring them to emergency surgery. So, and also the anal genital area, you want to make sure it's male or females. I've had 2 or 3 deliveries where this even physically they've had both genitals, so they would have to do some genetic testing or other means to determine when if it's male or female. So that's a very tricky subject issue. Again, it's case by case depending. You have to look and see if they're more male or more female, and you get into gender assignment. I've never been in a situation where they have to assign a gender because they were born with both, but usually I've seen them born with both. But for example, I've seen one with both male and female, but it was mainly male. So unfortunately, I don't follow them after they leave the hospital, so I don't know what the outcomes are, unfortunately. You're going to look at the back of the baby. So you're going to turn them over on its prone position, and you're going to go look at the back there. You want to make sure that the spine is straight. And at the back of the spine, you want to make sure that there's no, if there's a tuft of hair there, then you're going to suspect there's like a spinal issue. So you might have to rule out spinal bifida. A couple slides later, I'm going to talk about myomeningeals and care of spinal bifida and hydrocephalus. I'm going to mention it briefly. I know that you probably learned that in pediatrics, but it's part of neonate care because we see that's part of a neonatal complication. So we mention it briefly. Also, when you're in the back section, you're going to look at the skin. The darker skin infants are born, they may or may not, they may have Mongolian spots. Mongolian spots is this bluish color. It looks like bruising, but it's not a bruise. It's just a spot. And then you're going to gently put the baby back on its back, and then you're going to check the extremities. There's one thing called Ortolani response or Ortolani maneuver, where you get both legs and it kind of you kind of move the legs a little back a little bit. What you're basically looking is you're looking at both legs and you're looking at the gluteal folds. And if the gluteal folds are symmetrical, and that's good, that means that their hips are where they're supposed to be, and the legs and everything is good and symmetrical. However, if the gluteal folds, if one is not matching the other side, because they should be matching equally, but one is off, then you're going to you suspect hip dysplasia. So you have to run some tests such as x-rays and some other specialized tests to rule out hip dysplasia. This is fetal alcohol syndrome, and I need to add a picture there. But mainly for fetal alcohol syndrome babies, their eyes are a little bit more wide set, and then they have the thicker neck presence, and it's mainly the eyes that they're wide set, and with their jawline is kind of a little bit protruding as well. So those are the 3 things are signs of fetal alcohol syndrome. Okay, let's see. Okay, I'm gonna do these last 3 sites and I'm gonna stop. Okay, so with physiological responses to pain, there is a tool. One tool that they use is this modified pain assessment tool, and I think that's just an example. There's several tools out there to assess pain. Of course, they're not going to say, "Oh yeah, they can't rate the pain from 0 to 10 because they can't talk yet." But the scale takes an account of the newborn's behavior, and they use these little behavior sites, And so, and they rate them in the scale, and that's how they determine if a newborn has pain or not. However, what we could do as nurses, we could give them comfort measures if you do see some crying or any evidence of pain. Some comfort measures include breastfeeding. Again, you could breastfeed on demand. You could reposition them. You may swallow them. You could do, just hold them really tightly. You want to decrease environmental sensors, soothing, talking to the neonate, maybe non-nutritive sucking, allowing the neonate to grasp a finger just to comfort anything that could comfort the newborn, um, and also maybe try to cluster care. So you want to try to do, you just have to, again, everything's case by case, and just be considerate of the newborn's state, and depending on what kind of pain it has or what kind of procedures associated with it, you could do these things accordingly. As far as assessing for well-being, again, I mentioned thermoregulation. Keeping the baby warm. So when keeping the baby warm, I want to mention two concepts with thermoregulation. First, in order to regulate temperature, you have to the correct answer. If you have a question on the test, you have to use a sensor. So the sensor is usually in the warmer. They call it a warmer or isolette, and that's the word you're gonna be looking for in the exam. There's a little probe, and it's usually either a circle or a heart, and it's usually an adhesive in the back, and they apply it to this probe, and they apply it to the abdomen, to the skin, and one so that part is at the skin part, and the other end is on the monitor, and it's usually at the temperature where it's supposed to be at. It's the right like 90. It's equivalent to 97.5 or 98 degrees. So you have it on the set temperature. And that's the only way you can regulate temperatures with the sensor. However, in order to keep the baby warm, you want to think of other things. For example, you want to keep them away from cold draft. If they have like air vents, or you use warm blankets to vigorously dry the baby off from amniotic fluid, you want to make sure you move the wet blankets away from the skin, because what could happen is the evaporation process, and so that could lead to heat loss. So that's one way to prevent that. Also, too, after they're stabilized and they go to the open crib, you want to ensure that the baby's wearing a cap, because they can lose 40% of the heat is lost from the head if you don't have a cap. So it's really important that the baby wears a cap to cover the ears and the head in order to prevent heat loss. It doesn't regulate the heat; it prevents heat loss. You also want to and then also before giving a bath and after, you want to make sure the baby is warm. Okay, because it's so easy for the babies to get cold, and their systems are not as stable when they're born. They're kind of a little bit up and down. They're fluctuating because they're trying to find a way to stabilize themselves with the environment. They're so used to being in the mother's womb, they're not quite used to being on the outside. So it's really, really important to keep them warm. You want to make sure they have an adequate breathing pattern. Normal respirations for the infant is 30 to 60 breaths per minute. You want to record the first cry. You want to inspect and care for the umbilical cord. When you look at the cord, it should be 2 arteries and 1 vein. So remember AVA, artery, vein, artery. You can do eye care, meaning that you might give the erythromycin. In order to administer that, you press the lower conjunctiva and go from inner to outer canthus on each eye. You press down, you go the inner to outer, gently close the eye, take off the excess, the same you do the other. Infection precautions, heel stick, especially if they need to do glucose checks if you suspect they have gestational diabetes. So the next slide here, I wanted to show you where you do the heel stick. So in proportion, here's the foot. So you see this line. See these black marks here? So it's at the bottom, but it's at the back of the foot. It's not. So these are the areas where you do the heel stick. Okay, so you do it either, in these areas as well. And I'm gonna stop here. And for part 3, I'm gonna go ahead and make part 4. And if you have any questions, please feel free to reach out. Otherwise, have a great, I guess for me, it's great night. Okay, take care.